with that, again, we are part of the Weill Cornell Medicine Center for Comprehensive Spine Care, where we're involved with physiatry, pain management, neurosurgery, complementary medicine, psychology, and neurology. And I'm joined by two of my dear colleagues. First, Dr. Joshua Weaver, who's an assistant professor of clinical neurology here at Weill Cornell, sits about 2 doors down from me. And Dr. Dexter Sun, who's a clinical professor of neurology, also works with Weill Cornell and Hospital for Special Surgery. I've been working with both of these fine gentlemen for years, and it's a pleasure to have both of you on today. So thank you for joining me.
Thank you.
So let's talk first about what does neurology do in spinal diseases? Just walk us through that. Josh, maybe you can start us off.
Sure. Well, thank you for that intro, Neil. Basically, a neurologist in general is going to be more on the end of diagnosing where a spinal problem could be coming from. If you have pain in the arms or the legs or the neck or the back, numbness, tingling, weakness, all of these things we would evaluate first with a thorough history and examination. Sometimes we'll order some diagnostic testing, which we'll talk about a little later. And then a lot of times we can handle the initial round of medical management. There's a lot of medications that we can offer, as well as some non-medication treatments, including physical therapy and things of that nature. We also are able to decide at that point if that's working or not, and if we need to have patients get more potentially invasive procedures such as injections or possibly surgery, and we would rely on our other colleagues in the spine center, such as physiatry or pain management or neurosurgery, to help us out with the management. So that's the basic gist of what we would do. We're often the first line in many of these patients when they come in.
Dexter, tell us about what you have found in your experience, how you work as part of the team for spine care.
Right. Thank you very much for inviting me as a neurologist, because I'm very specialized neurologist in spine disorder. Because as we always joking, most of the neurologists I know any nerve system above the neck, but a very few neurologists knows the spine neurology. So I give talk around the world about the spine neurology because I have a lot of experience in spine neurology, because I'm working at the NewYork-Presbyterian Hospital and Hospital for Special Surgery, mainly with the spine center for more than 20 years. So I had a lot of experience. So I like to share with you guys my own experience. Number one, I think, Josh talked about the neurology role in spine disorder. I think he covered pretty well. So I just like to elaborate a little bit more into his topics and his scope. So first of all, I think it's very confusing. When you have a neck pain, low back pain, pain shooting onto the arm or leg, who are you going to see? Frequently, you're going to see internal medicine doctor. Internal medicine doctor said, oh, we can refer to surgeon. I can send you to pain management. I can send to a rehab doctor. We can send you to neurologist. So always very confusing. So as a layman, always get confused who I should see first. Frequently, in the real world, people see different specialties. But I think from my experience, see a neurologist is quite a good choice. Why? Neurologists, if we specialize in the spine, so we understand the neurology issue and the spine issue can give you, as a gatekeeper to analysis of what it is, what kind of problem, and then we can package what we have and then came out a very accurate diagnosis and treatment plan. So the first topic is here, we talk about neurology role. I made a list here. First is diagnosis. When you have a neck pain or low back pain, they can have so many different issues, just even spine. Could it be just neck pain? Could it be a muscle pain? Nothing serious. Low back have a lot of pain. Could it be muscular rather than spine issue? But for us as a neurologist, we really want to get a clear diagnosis for you. So if it's a muscular pain, we treat it as a muscular issue. If it's a spine issue, and then we have to really sort it out what type of the spine issue. Why? Spine have so many different type of issue. Usually people just heard about disc herniation. It's not only have a disc herniation. When you have a spine pain, neck pain, low back pain, you could have a disc herniation. You could have a bone spur. You could have a spinal stenosis. You can have could be potentially have a tumor. So have so many different things. So for neurologists, our role is trying to help you to get a very clear diagnosis. Without a clear diagnosis, we don't know how to treat, So I think that's the first issue. Second is frequently people have a neck pain, low back pain shooting onto the leg or arm, not necessarily a spine problem. Could it be some other disorder, neurology disorder? For example, a patient have a neck pain, have some pain shooting onto the arm. Could it be shoulder problem? Also, could it be branchial plexus? The nerve in the neck area have a plexus, have inflammation or something compress our nerve, cause a similar issue. If we get a correct diagnosis and then we know how to treat it. But for neurologists, we understand neurology problems, so we make a differential diagnosis, make sure your problem is from the spine. So that's the reason we talk about differential diagnosis. And the third, and Joshua mentioned, usually in the early stage, without need is clear indication for surgery, we provide conservative treatment or management. It's not mean we treat patient with all technique. But for example, neurologists frequently prescribe the pain medication or prescribe a prescription to go to physical therapy. And also sometimes frequently we send patients to pain management. But before we send to the pain management people, we really understand the diagnosis. So we make pain management people much easier to understand exactly what they are going to do. It's a trigger point injection or epidural injection or facet injection or different type of the injection. So a lot of information we need to provide. So we not only provide some conservative treatment, we also to manage the patient to send to different specialty. And then
Thank you, Dexter. Yeah, that's great. And I certainly know that we use both of you guys on some really challenging cases, in the past, and some of the testing that we've done together has really changed the course of treatment, maybe even prevented somebody from needing surgery.
Right.
One of the tests that you guys do is an EMG test or electromyography.
Right.
I wanted to actually talk about that for a moment because it's so important.
Sure.
1 second, let me just get to, I know there was a great slide there.
I have a slice here, right?
Yeah. So, well,
backwards.
This was interesting.
Yeah.
So this looks like a really complex machine. Josh, walk me through what is this? What do we use this for?
So I like how Dexter said a lot of neurologists is really the neck up. A lot of neurologists go into the field because the brain is so fascinating, which it is. But a lot of us, like Dexter and myself, are able to evaluate the nerves coming out of the neck into the arms and the legs. And this test we both do, it's a nerve conduction study, that NCS there, and EMG, which is electromyography. And this is the basic setup. This is how it might look. There are different kinds that are out there, but that's the one we have here at the Spine Center. Basically what it does is it looks at the electrical properties of the nerves. So if you have nerve injury somewhere, so let's say you have a bone spur or you have a disc herniation or whatever, or both, compressing a nerve root, we're able to use this test to figure out exactly what nerve roots or nerves are involved. We're able to figure out how long it's been going on for. We're able to figure out, how much damage to the nerve there is. Sometimes a patient can come in and have numbness, tingling, pain, and it can be pretty bad, and it could have been going on for months. And you could have two patients look exactly the same. One could have really severe nerve damage, and the other may just have some nerve irritation and not a lot of nerve damage. And this test can actually help sort that out a little bit. And that's actually really important. Sometimes pictures that we get, like MRIs, don't always clue us in as to exactly how much damage is being done to the nerve. And especially if it's a situation where a surgeon may say, I'm not sure if we need to do surgery more urgently or if we should watch this and try injections or physical therapy, this test can often help us guide us as another piece of data to sort of push us in a certain direction in terms of where to go with the treatment. So it's a really valuable test to have.
So tell me a little bit about the training involved in the specialization that you guys have gone through for this. What type of neurologist would one look for?
Okay, so generally speaking, you need to finish neurology training for the fellowship. Usually we finish the entire 4 years neurology training, and then we usually take a 1 year fellowship to really learn the detailed technique of this EMG study. So you should set up this. However, sometimes during the resident program, we also train our resident, how to do it, but it's a very brief one. But if you want to be really good electromyographer, and then generally speaking, we usually go for 1 year fellowship. I did a 1 year fellowship. I think Josh, you also did a 1 year fellowship, right?
Yeah, exactly.
And what is that fellowship called?
Huh?
What is it called?
Called the electromyographer.
Yeah, there's
right.
And I'll just dovetail off of what
the EMG,
I'll dovetail off of what Dexter said. So there's actually two kinds of fellowships that can be done where you learn this in a great detail. One is a neuromuscular fellowship, which is a little more clinically oriented to a lot of neuromuscular problems that you muscle or nerve. And what I did, which was at Cornell, was a neurophysiology fellowship where you basically just learn the electrical aspects, the EMG aspects of the nerve. And I actually really want to stress what Dexter said, which is, you do 4 years of a neurology residency, and then you do a year at least of a fellowship to really learn how to do this procedure. It's actually really important because there are many non-neurology or even neurologists that weren't trained this way who, can be good at doing this test. But sometimes you'll get, I see reports that we get from other practitioners which are not the best quality. It doesn't always happen, but I think to ensure that if you're going to get this test, it's good to make sure you find a practitioner, either a physiatrist or a neurologist who has gone through sort of rigorous training and really understands the nuances electrically of this test. It's not the most pleasant test to go through for those
in the audience. Let's talk about that. A couple of people have talked about that in the chat, that it's
exactly.
How do you prep for it, and is it painful?
Yeah, I would say, and Dexter, I'd love to hear your thoughts too. You've been doing this for a long time, but I think the EMG test can be painful, and I think this is another one where if you're not as experienced, sometimes people will really crank up. Basically, just to walk through how the test works, you give an electrical stimulation, so you feel a little shock, and we stimulate the nerve to see how well it's responding, right? Sometimes when you go to a place to get this done, they try to be as fast as possible, and they crank up the voltage all the way up to 100, and that can hurt, when you do that. But the thing is, you don't have to do that. If you've been doing this as long as Dexter and I have been doing this, there's ways to do it that are much more gentle, and you can have an EMG experience which is a much more manageable and tolerable experience. So I have a lot of people who've come to my office who had horror stories, from prior EMGs, and then we do it, and they say, "Oh, that wasn't as bad." And it's not something you want to ever really do.
I certainly can vouch for that. I haven't seen anybody run out of your office, so that's pretty true.
Yeah.
What's your experience, Dexter? Have you generally found people tolerate it pretty well?
Yeah, I think most of my patients tolerate very well. I think, so many years, and also when I was Mass General, they teach a lot of trick. So you definitely need a art. When you do this test, it's not like a test, you just put the electric current on patient, and they're freaking out and then feel discomfort. So the major issue is each patient coming, I will spend the time to tell them exactly what kind of test, what are you expecting. So the patient already feel calm now. When you do it, you need a gentle, you let the patient on the drive seat, every step let the patient know. And then turns out that most of my patients, they all can tolerate it without problem. I just make a joke. I have a patient that 2 weeks ago by someone else did it. She told me she rather Weill, no more EMG. Weill, rather Weill, no more EMG. Come to me, no problem at all. So I always tell people that's a joke, but there's a real story, when I practice. So I think the way how you do it, how you gently and how to explain to the patient, and you working with the patient, and then will be no problem. But if you are not talk to the patient, started doing some testing, and the patient is usually very smart. They looked online, they look to say, oh, this test will be discomfort. They already psychologically already feel nervous. So for us, our job is first of all to calm the people down and then explain everything, every step. Then you working, then should be okay.
Let me ask a silly question, but does pain medicine impact this for better or worse? Does it ruin the quality of the test?
No, it's not going to affect the test results, but the pain medication basically is not really will make a difference. So we're saying to you, some people feel a little bit nervous. You take a little bit Valium, it's okay. You see that I take a Percocet, I'm coming for MR scan. There's no difference. I don't see any difference.
Yeah,
so
I think
my
some
opinion,
people.
It's the only reason to take pain medication.
Yeah, some people will take maybe, especially if there's a lot of anxiety surrounding it, they might take an anti-anxiety medication and it just helps calm them a little bit before the test. And often that's enough, to get through. But the vast majority of people really do fine without any medication whatsoever. It's actually a fairly tolerable test. And I think the big important thing to take away from it is it's an extremely useful test. I mean, you really get a lot of important information that really can change the management in what we're doing. And that's why we put people through it, is because it actually matters.
Yeah. So also let me add on this. I think people frequently ask, why I need EMG? When they come into a consultation for the spine, why is suddenly out of blue talk about you need a nerve test? We layman, we use a nerve test, but the fancy name we call it EMG test. So I usually explain to patient, it's a very clear cut. It's a MR scan will show you a structure problem. It's only morphology, basically structure. But we're not telling the nerve function, the nerve root damage or not. So in order to define the nerve function, we need a nerve conduction EMG study. That's the only test can tell me the nerve function or not. And then so as Josh mentioned, this test will localize which nerve root, whether have a damage or not. It's a C5 or C6 or C7 if in the lower back, L2, L3, 4. We need to define whether, number one, the answer is whether there's a nerve damage or not. So the EMG will tell us. If yes, what level? It's a C5, C6, because sometimes the MR scan will show this multiple level. The pain is not typical in the specific dermatome of the nerve root. So the EMG definitely can help us to define whether have a nerve damage or not. If yes, where is the nerve damage and how many level? It's very important for our management, including the epidural injection or the pain management people. Also in the future, in case patient need a surgery, also it's important for surgeon to understand whether you have a nerve root damage. If yes, what level? So it's very important information. The last one is very important is sometimes I mentioned to you, people can have a pain shooting down. You have a disc. You did the MR scan, show some disc there. Turns out that we are neurologists, are very experienced. Turns out that a lot of patients have overlapping symptoms. It's not from the neck. It's from the branchial plexus, have acute branchial neuritis. So if you make a mistake, so EMG, if you're good EMG people, you can dissociate the nerve root damage from the neck or from the branchial plexus. Why? The treatment will be totally different. So that people, if MR scan showed a few little discs and then have a pain shooting onto the arm, but it turns out it's branchial neuritis. So you do all the epidural injection, even go for surgery, will be totally wrong. So that's the reason the EMG also will help us to distinguish the overlapping condition and then to dissociate whether this is different from the spine or not. It's very important.
Well, you've sold me on getting it. I may come and schedule one with you. A couple of questions that came up about how long does it take? What's the average amount of time?
It depends. Yeah. I mean, if you're doing, sometimes you only need to check one arm or one leg, and that can actually be 15 minutes. You can get that done. In some cases, it's a lot more complicated and you have to do 3 or even all 4 limbs. And when that happens, it takes longer. So it really just depends on you know, what you're testing for. I would say the average would be anywhere from 20 to 45 minutes, depending on how much. We usually allot a full hour just to make sure there's a little bit of a buffer here at the Spine Center. But yeah, it's going to be somewhere in that range.
I agree. The time is about 30 to 45 minutes. That's the range. And
one of the things you talked about was having the test elsewhere and then coming to have it interpreted by you guys.
Mm-hmm.
How often does a test need to be repeated where the quality, you know, just wasn't there? Like how often does that occur?
Josh, do you want me to answer this question?
Sure.
So what's happened is very interesting. What's happened 20 years ago, I trained at Mass General for EMG. I came back and so a lot of patients bring the previous EMG, want to show me, or some doctor tell me, I did EMG, you're not supposed to repeat my EMG. And then this is the EMG results, boom, boom, boom. I see the wait seconds, you know. I'm like a special trained EMG guy. I think, you know, I would be much confident if I do repeat EMG. So what I mean is EMG and MR scan is totally different things. MR scan, if you get an MR scan in New Jersey, Rhode Island, or whatever, and then if the quality is not good, if neurologists review the quality is not good, even they talk about discrimination, etc. I would tell patient, I'm not really sure the quality, but I see, yes, there's something. So in other words, it's a quite objective test. But when you do the EMG, it's so subjective, depends on your skill. So in other words, it's like a neurology examination. We do a neurology exam, the strength, sensory, reflex. So the EMG basically is an extension of a neurology examination. It's not like as you think we just do a test. You need the neurology examination, you have the knowledge and then do the EMG, and then came out the results will be accurate. So Josh and I frequently saw people get EMG all over the place. A patient coming in have some neck pain on the right side of the right arm. The EMG report have the C5, C6 radiculopathy, nerve damage on both sides. Even as a neurologist, I know this test is totally wrong. You know, it's not right. Examination, they're completely strong, no weakness, reflex is fine. So that's the reason EMG frequently, if I really want it, let's say a patient, I need to do EMG. Why I examine, I think that's necessary. I frequently will tell patients, unfortunately, I like to repeat the EMG by myself. So then I give you another scenario people will understand. You have a neurologist examined in Florida. They say that you have what disease? If you come to see me and say, Dr. Sun, I just examined by neurologist, you cannot examine me. Just look at me, hear my history, and tell me, what do you think? I don't do that. I feel this is insane because I cannot examine you. So I have the same philosophy. I don't know whether Josh agree with me because EMG is so subjective, and usually I have to trust my own judgment because otherwise I tell you, I found so many studies mistakes. It's not me, I want to criticize people, but I just feel this is my neurology examination. If you want me in a second opinion, I really need a hands-on to tell you the best knowledge from myself, rather than say, oh yeah, Josh did the EMG, see the nerve all damaged. Thank you very much. Yeah, you have all the nerve damage. That I feel not responsible. It's not good neurologist.
Well, thank you for that. We have a couple of questions about peripheral neuropathy, you know, slightly different than our spine discussion. Couple of things about using it as a diagnosis tool, and does this neuropathy generally progress, and do you need these tests periodically? I think you guys kind of answered that before, that you do repeat them from time to time for checking progression.
Yeah, you will check that. I think in terms of neuropathy, it's not exactly a spinal issue. In fact, this is actually one of the reasons this nerve test can be helpful. You know, someone has a lot of back pain. They also have numbness and tingling in their feet. And, you know, is it coming from your back, or is it a problem? So a neuropathy is a problem with the nerves directly in the feet. And some people have both. Some people just have neuropathy, but they have maybe some muscle spasm in their back, So to Dexter's point, it's really important to try to parse out, where these things are coming from, because no one wants to go through an injection or surgery unnecessarily. So finding evidence of a neuropathy on the nerve test tells you that there's a problem directly with the nerves in the feet. It's not coming from the back, and that can be really useful. In terms of, what do you do with that information? Well, it depends on the kind of neuropathy. There's a lot of different kinds out there. This test is also useful to see, what parts of the nerves are affected. Sometimes certain neuropathies are treated differently than others. And that leads us down this path of trying to figure out what the cause is, diabetes being the most common, but there are literally hundreds of potential causes of neuropathy. And that's something we try to work on as well if we find that.
Yeah, walk me through that. I've always been fascinated by, what the work you guys do and your colleagues when you're looking at peripheral neuropathy, just the amount of testing that goes through. I mean, if you can sort of summarize that briefly for our viewers.
Sure, and Dexter, you can add to this. I think in general, we do something pretty similar. Most neurologists who treat this or diagnose this, when you find a neuropathy, you're looking to see what kind of neuropathy. So some neuropathies, the most common neuropathy is going to affect the motor nerves that go to the muscles and the sensory nerves that allow you to feel, sensation in your skin. And it's usually what's called an axonal neuropathy. It's the inner part of the nerve that's really primarily affected. There are some neuropathies that just affect the sensory nerves. There are some that just affect the motor nerves. There are some that also affect the outside of the nerve. There's a little sheath that kind of, it's like insulating the nerves called myelin. And if that's affected primarily, it's called a demyelinating neuropathy. And the EMG test will actually be able to tell you, all of that in terms of what's affected. And depending on what we see, we generally then do a bunch of blood tests to try to figure out what the underlying cause is. Someone mentioned, what's the treatment if it's not caused by diabetes? Well, if it's a vitamin B12 deficiency, we would treat with B12. If it's Lyme disease, we would treat with doxycycline, So it really depends on what the underlying cause is. And so very frequently we'll send off a lot of blood tests because there are so many possible causes. It's not unusual to have even 9, 10, 11 little tubes of blood, taken to really look for all of those potential causes. And then we try to treat, if we find an abnormality in the blood test, we try to treat that.
Great.
Josh, in terms of shifting a little bit back towards the spine, since we are a spine center, somebody asked about the appropriateness of the EMG test when after surgery things aren't going so well. How often do you think about EMG tests there, and how often do you use EMG versus MRI? It sounds like MRI is almost like gold standard.
Yeah.
So how often do you get an EMG test then?
So Neel, number one, I think after the most of surgery, you don't require for EMG study because the patient getting better and better. You really don't need, unless some patient before the surgery have a foot drop, for example, nerve root damage. After 6 months, it's still not improving, and then sometimes the surgeon said, "Could you repeat the EMG to see how much regeneration?" We do it. So the only time we talk about some very small portion of the patient after surgery not doing well, pain still a lot of pain, or continue to have a significant weakness, patient will come back to you, say, no, you did a surgery, nothing improved or whatever. Then frequently the patient come to see us. And then in that way, we need to do the workup. So the first one, we always repeat the image study to make sure surgery, everything's perfect. And then second, sometimes we do EMG to figure out whether they have some other issue or the nerve is not recovered. And then there's one very special type of the complication from surgery, which a lot of people probably don't know, even sometimes surgery don't know, because I'm working in the spine center at HSS, they have more cases. What's happening, in the old days, they do much more surgery. So what I mean is a patient come in and said, oh, I have a lot of low back pain, have some pain shooting down to the leg. For example, that case. After surgery, waking up, they call the neurologist, say that, now my both foot dropped on both sides after surgery. Of course, the patient will be really upset. Surgeon will be really nervous. So first things, you repeat the MR scan. Found nothing. Everything did a beautiful surgery. So why this patient suddenly the leg become weak, or did the surgery in the arm, both arms become weak, or even tingling numbness? Turns out that's one special complication we call the stretch injury. People have a severe scoliosis or spinal stenosis when they open up, reconstruct the spine, and then sometimes they have a little bit nerve root stretch, and then cause the temporary nerve damage, so induce a foot drop or arm weakness. That's is a well documented, we call a surgical stretch nerve injury. So that part is frequently we do a nerve testing to document how many nerve damage and how much damage. However, most of that kind of patient eventually will recover in 6 months to 8 months. So the EMG sometimes will help us to define the problem, And also we're told this is real or not, because sometimes people have psychologically after surgery say, I cannot move anymore. And then the nerve testing will give us very confident, hey, listen, Dr. Smith, you did a surgery now. The nerve damage is real. It's not like a patient is just freaking out. So then we also will direct the patient. The MR scan looks fine, relax. This is called a stretch injury. Even patient will get upset, but we reassure the patient through physical therapy, etc. 6 to 8 months, most patient will recover. That's a lot of paper published on this.
And Neel, I just wanted to add in there, that was great, Dexter. I think MRI is a very useful test. EMG is a very useful test. They're just different. I don't think there's a necessarily gold standard sort of sense there. It's just two different types of tests. So really one gives you a good picture and one gives you a good sense of the functioning of the nerves, So it's more of an imaging test versus a functional test that you can use. And they often go hand in hand. So, you can use both of them to really help guide you. I think more importantly though, and Dexter, you mentioned this before, this nerve test is really an extension, as you mentioned, of our physical examination. And I just want to go back to that because really, although we do a year of fellowship training to learn how to do this test, we go through 4 years of residency training to really learn the subtle neurological findings that go throughout the body and how to deal with that. The slide right before this just shows some of the tools that we use frequently on our exam. So we do maneuvers, physical exam maneuvers. We will move people's arms and legs around and test strength, and we do functional tests like this is the straight leg test. And we do reflex testing. So there's some reflex hammers you might see on the left there. And we check vibration sense. We look for temperature sense. And we use all these little tools to give, actually, probably more importantly than any other image or functional test that we do, our exam really tells us so much more about what's happening to the person. And so that's actually a big part of what neurologists do. Which is we really think we're really able, after all of our years of training, to pick up on subtle clues that the body has, tells us where the problem is and what's going on. The EMG and the MRI, that really just kind of helps to confirm what's happening and sometimes can show us things that we weren't expecting, so it's useful. But really, that's why a lot of people rely on neurologists. I think sometimes there could be multiple things going on. You've got bad disc herniations in the neck, the lower back, you've got a neuropathy, you've got carpal tunnel syndrome. It's really hard sometimes to parse all that out. And very frequently we'll have other non-neurologists send to us to try to help, parse out those subtle clues to try to figure out what's going on.
Certainly, I make use of both of you guys for that exact reason. And we've had cases of brachial neuritis recently that originally were very much thought to be cervical spine issues. So you certainly are correct in that.
Yeah.
We're coming close to the end. I wanted to, we spent a lot of time talking about EMGs, and certainly that's an important thing, but you guys do so much more. We've talked about your examination process and so forth. What's new and cutting edge in the field of neurology in terms of spine? What are you guys really excited about?
You talk about the diagnosis or the treatment?
The floor is yours, but it sounds like we spent a lot of time on diagnosis. But
Yeah.
just because we have this great
Yeah.
facility at Weill Cornell, we have access to a lot of things. What is new and exciting?
I understand. So I think that first of all, I'd like to re-emphasize the neurology role in spine disorders is very, very important. Through our thorough history taking, neurology detailed examination, image study, review, and electrophysiology study. So for us, so we want to be getting a very, very accurate diagnosis. That's very important. This also is a cutting edge, because what's happened, if you don't know how to so accurately get diagnosis, your treatment could be completely wrong. So that part I want to re-emphasize. Even the technology image study, we're getting better and better. The resolution is better, and then we have all the good image study. Neurophysiology, we also see improvement. So then the issue is for the treatment. Treatment, I think that for my understanding, the treatment, let's say medication also have a lot of new medication. I don't need to talk about all the details. So the physical therapy is still tradition. There's nothing cutting edge, new stuff came out. But the pain management part, they have so many new technology, right? You guys, even injection have more than 30 years to have a technology, but even the injection have a different way to do it. Even the X-ray guidance is different. And then now you also have a spinal cord stimulator. That's a lot of radio frequencies. So I'm not going to talk about all the pain cutting edge stuff, but I can tell there's a lot of new pain management stuff going on there besides the medication. And then even for me, and I'm working on, even the injection. For example, injection, Neil, I'd step on your toe to, talk about your stuff. Now they also use some PRP injection to regenerate the disc. I know there's a lot of people came out there, like Gregory Lutz at HSS did quite a lot. I saw the PRP to regenerate the disc. That's the cutting edge, it's new stuff. And then stem cell. Stem cell now is like a multi-center doing study, and then clinical trial, phase 2 or test. They go into the phase 3, and it's very exciting. And a lot of people working on the stem cell. I think that's one of the very promising areas. So, and then we talk about all the injection, pain management, regeneration of spine. That's usually the interventional pain management, Dr. Mehta's field. And then we talk about the other part. For example, I'm using the EPAD. EPAD is a positive treatment for all the spine pain. Always combination. It's not like a one treatment. We use the EPAD as a switch technology to initially treat for tendon injury, joint injury, and then turns out that for neck and low back treatment also working really, really well. Basically, the theory is they can break down all the scar tissue among the muscle fibers to reduce the inflammation, let the underlying blood vessel regrow. And we also use some ultrasound, electrostimulation. Sometimes I even use a little bit traditional Chinese cupping to help. So that's no, and then surgery. Surgery, of course, I'm not going to talk about all the surgery. Surgery have so many new technology and a new way to do it. Dr. Hardo now is like the pioneer.
Yeah, we've had Roger on here many times, so
right.
we've
I think the surgery
this.
have so many. This is why I send so many patients to Dr. Hardo, because what that means is he also have a lot of computer assisted surgery and also minimal surgery. A lot of patients, they don't want a big surgery, or the health is not allowed for a big surgery. So Dr. Hardo have the technique for the minimal invasive surgery, even as outpatient surgery. So we get very excited, as a neurologist to working with the spine center.
So we got a couple questions I want to get to before we wrap up. There was a comment about scoliosis and affecting nerves. How do you use your testing for that?
Okay. It's really, in my mind, the same thing we would do for any kind of spine disorder, herniated discs, bone spurs, scoliosis. There's a lot of reasons why nerves can get impacted and why muscles and bone can get impacted. So we do the same sort of thing. We do a history and our physical exam, and we often get an image, and we often get a nerve test, and we try to put it all together. It's just one more reason why you might have pain. And scoliosis, has some slightly different treatment options available to it, including bracing and different ideas for surgery. But it's all kind of the same process, what we would do.
I agree. The evaluation of the nerve compression or damage is the same process as we talk about history, physical examination, image study, and electrophysiology studies.
So for the people in the chat, Mark Rubin, Mary Dugan, certainly if you're not already a patient here, we certainly welcome it. And I thank my good friends, Dr. Weaver, Dr. Sun, some of the smartest people I know, sharing their life's work and how they've really helped change the specificity and accuracy of diagnosis using the tools that they have beyond just MRIs. I again welcome everybody to our future episodes every 2 weeks, and also to revisit our past ones that are archived on YouTube. And with that, here is our website for that. And I thank everybody and have a good night.
Thank you.
Good night, everyone. Thank you.